So our next panel is industry discussion. These are going to be some lightning talks. And we've asked our panelists, again, to not use slides and to literally try to get an idea across in around 2 minutes. And then we will go to an active conversation. So listen carefully, because these 2-minute ideas now are going to drive the conversation that we have for the rest of the time. So the title of this panel, again, is What are the solutions coming out of industry? We're going to spend... Who has changed the game for you? I heard something, but I guess that was experience. What are the solutions coming out of industry? We're going to spend 35 minutes. Let me introduce the panel. Marshall Ruffin, founder and chief executive officer at Salutary, Inc. We have Susan Kressly of Kressly Pediatrics and medical director of the office Practicum. Michael Wang, CEO and founder of Inspirin, and Jacqueline Gerhart, director of clinician engagement at Epic. We've got Jeff Wall, senior director of clinical innovation at Cerner, and we have Peter Durlach, senior vice president of healthcare strategy and new business development at Nuance Communications. So as you can see in these next set of 2-minute talks, we're going to cover the whole gambit of what's coming in the future, what's here now. And with that, I'm going to ask Marshall to kick off his 2-minute idea presentation.
Thanks, Ken, very much. Salutary is in the business of using the full electronic medical record to predict outcomes for patients. And we're using natural language processing extensively to extract from physicians' notes, radiology interpretations, as well as lab reports, data that we use to predict clinical outcomes. We're having extraordinary success in predicting perinatal complications based on extracting data not only from obstetricians' notes, but also from their fetal ultrasounds. In fact, we have better predictions for preeclampsia, postpartum hemorrhage, and premature birth than any in the published literature. So the message I want to send is fairly simple. The more we can structure the data that physicians produce, the more accurate our predictions will be. And I would argue in value-based care, predictions of future outcomes will become more and more important to health systems.
All right. Thank you, Marshall. So prediction. Susan.
So he wants more data and I want more narrative. So as a pediatrician who understands the complexity and the wellness and health journey of families and a complex care team, my focus is really letting this be driven not from us as the healthcare perspective, but from the patient and family and care team perspective. And all of this documentation, first of all, we should be deciding what is worth documenting to begin with, and in what form it should be documented, stored, and easily accessible by the myriads of people who are going to consume it, because how they consume it is going to be different. And we need to also figure out how it's living. So this is an ongoing conversation, not siloed episodes of care. And most importantly to me, we have to do this in a way that does not worsen disparities of care. Technology has the potential to just make disparities worse. And we have to figure out what that looks like so that everybody has access to the best information and clinicians are facilitated in their relationships with their patients.
Great. And everyone's really keeping to this 2 minutes and even down to 1 minute. So feel free to take a leisurely 2 minutes if you like. Michael Wang. Maybe we don't have Michael Wang. Okay. Jacqueline Gerhart, Epic.
Hi, so I'd like to echo the two that just spoke. I think both of those are very fascinating and would be helpful. I'm thinking back to the basics. So just as long as we are going with AI and following machine learning and using voice, we also want to right now be able to use some of the tools that are already in EHRs to be able to leverage decreasing note bloat and being able to get back to our patient. So my focus has been on looking at ways you can use the encounter report to describe things like labs and other stuff that you've already done so that you don't have to double document. And also to some of the points of the earlier panel, really trying to leverage how patients can put their own words into the record so that they are really part of the care team and leaning on that care team to be able to create notes out of that rather than leveraging just a clinician's time. To harken back to one of the other talks, I agree that time is of the essence with your patients, and being able to show compassion to your patients is extraordinarily important. So I'm hopeful that we can use tools within the EHR to help.
Great. And Jeff.
Hi. We're at Cerner, we're really focusing on care team communications going forward. The removal of the restrictions of who can contribute to the patient's note, you know, like medical students, MAs, nurses, and all that over the past couple of years is really kind of removes a layer of distraction, really, that we believe will facilitate better care team documentation. There really isn't, in our minds, a difference between physician documentation and nursing documentation. There's really just patient documentation. And each role in the hospital has their own slice of that that's important to them and that they provide. And it all really comes together, we think, as a singular longitudinal plan of care that we all contribute to, whether we're doctors, we're nurses, we're social workers, therapists, and we all need to be working together in a unified multi-contributor fashion to create that care team documentation, that long-term plan of care. That same long-term plan of care, though, also has to live inside and outside of the EMR. So working closely with our interoperability folks, we are building, you know, ways that we can make sure that that same plan of care is not only pushed to the portal, but that plan of care also includes not only the goals, activities, health concerns of the clinical team, but also the patient. So that patient's health concern is, you know, I just want to be able to dance at my granddaughter's wedding. That's as important frequently as the other things that we add to it. So getting that care plan pushed into the patient's portal so they can sign off on it, pushing that care plan up to all your connected sources, whether that's directly through your own organization, through the HIE, or even through a smart app, so that other clinicians using other EMRs can access that same singular plan of care. That's a really important concept for us.
Great. Thank you, Jeff. And Peter.
Yeah, hey, thanks, Ken. Thanks for the time, and good to be here. And I have a lot of old friends on this call, so nice to sort of see some of you anyway. So yeah, so you know, we at Nuance, you know, we've been in the business of trying to bring back what we called, actually I think we stole it from somebody, this idea of bringing back joy to medicine many years ago. And there's a famous picture that Bob Wachter from USSF put in JAMA back in 2012, many of you seen, of the 13-year-old girl's drawing of her visit where she's with her family and she's on the table and the doc's off in the corner, crunched over, head down, looking at the computer. So part of the mission inside our company is really what we do is to say, turn the chair around. So really aligned with the mission here of trying to do our small part to, you know, give back time to clinicians so that they can take care of patients in their own, you know, kind of work-life balance. So about 4 or 5 years ago, as we were thinking about what came next after Dragon, which again, as many of you know, is sort of the dominant product physicians use today to document and to Epic or Cerner and others, and working with Jeff and Jackie's team, is we had a discussion about what that would be. And what came out of this idea at the time, this was in 2015, the idea of ambient clinical intelligence. Why couldn't we start with the conversation between the clinicians and the patient as the beginning of the creation of the note and the downstream artifacts that you need from structured data out of the note to drive coding, quality, and compliance that are often the bane of clinicians' existence. And we said, wow, that's a really hard problem for many reasons, as many of you know. But we said, this is our business. If we're not going to do it, someone's going to do it. We should do it. So we jumped into that. And earlier this year, we launched a product called the Dragon Ambient Experience, DAX, which is really a state-of-the-art product. It's still got a journey, a way to go. but we've made incredible progress. So the way it works is you can have a conversation, multiple people in a physical or virtual visit. We record the conversation, we diarize the conversation so we know who's speaking, and then we convert that colloquial conversation using neural nets into a clinical note as if the clinician had dictated it or typed it in the traditional way. We do it. It's not perfect, but the technology's advanced tremendously in terms of the performance. It's quite stunning, actually, to see that. And a couple of interesting kind of data points. Number one, there was some discussion about synthetic notes before. The way the machine works is it learns individual physician patterns. So you can have one conversation, and depending on whose model you're using, have it appear very differently in the structure and the words that are used based on what physicians usually document themselves. So it's an amazingly personalized system, which feels like the clinician has done it, but has all the rich patient narrative, often better than what clinicians write, with a lot of the structured data. And we're seeing, you know, really good early results. The early data, again, we've got a ways to go, is we're seeing burnout. Again, we don't solve all the burnout problems, obviously. We only do a small part of that. There's reduction from about 72% to 17%. We give back an hour or two a day, depending on how many patients someone sees. The physicians report tremendous reduction in cognitive load, because when they're seeing the patients, they don't have to worry about all this other stuff and taking notes. They can focus on the patient. They actually have time for lunch and to pajama time. They don't have to do as much. And we've also started to get some data from clients where the impact on the patient, as Eric mentioned earlier, seems quite significant. We don't have enough data to back this up scientifically yet, but the early anecdotal data is we're seeing data that says 77% of the patients in general feel the experience is materially better because the physician seems to be paying more attention to them and taking more time to explain what is going on. The other one quick thing, and then I'll wrap, is one really cool part is that that conversation not only informs the note and has tremendous richness of the patient story, but there's tremendous interest to provide that back to the family in a lot of cases as a part of really educating them and their family about what is going on, what was described. So we really think it's the beginning of a very different paradigm of how a lot of documentation is done. And then the last piece, not to overwhelm it, but someone had mentioned there are times where the clinician wants to say something, but it's not in the conversation. So we see this very much as a multimodal capability. So in the solution, you can record the conversation and turn that into a note, but you also have the traditional functionality where the physician, with or without the patient present, can dictate something explicitly or issue a command. Epic has this as, hey, Epic, in Cerner, the hey, Cerner for a virtual assistant. So you have the ability to control the EHR with explicit queue up an order, send a quick actions, or dictate something in addition to the ambient thing. And we think the combination of those is critical. It's not one or the other, because as you all know, the workflows are different. What you want to do when is different. So it's really the coming together of this. So I think we're in the early stages of a very significant shift in at least one part of the solution to this problem. Obviously, there are huge other issues related to regulatory requirements and other things that we certainly don't claim to have any effect on from the Nuance side. So back to you, Ken.
Thank you, Peter. So let's get at this issue. And Peter pointed to a solution, which is Hey Epic, Hey Cerner, where you can switch into something more structured, perhaps. Marshall, you're a fan of structured data. Is the conversation, and I'm picking up on some chatter that's going on here in the chat, where there is some skepticism about the role of conversation in producing the documentation we need, or at least wanting to open up that to broader horizons. How optimistic are you that conversation will produce some of the structured data that you value the most?
I'm actually not very optimistic about it. I mean, I'd love to say that I am, but I think physicians are going to have to create their notes in a structured setting. You alluded to the pilots and the vocabulary they use. I agree with you. It's a much more limited vocabulary, but it's also very effective in communicating between the ground-based who are guiding the flights and the pilots in the planes. I don't think we're going to reach nirvana anytime soon where doctors and patients can say whatever they want, and we end up with data in a format we can use for predictive modeling. And the predictive modeling arguably is a very important outcome of our documentation, because it will allow us not only to be more precise in our predictions for patients, but it will allow us to engage the patients in a way with specificity. Vague generalities aren't very helpful to patients or to referring physicians. We need to be as specific as we can be. We're using a lot of natural language processing. We're using physician notes. They're very important. I would argue the more structured we can make them, the more accurate our predictions will be.
So let me go to Jackie. So Jackie, you're very used to having physicians enter structured data, and also you very adept at dealing with dictated data. How would you ingest data produced from a conversation by the Nuance approach?
Yeah, great question. So it gets back to what Peter was asking or discussing about how there's the discrete type, like the, hey, Epic, show me the labs. And then there's the ambient type where you would do, like you just said, adjusting the data. The goal would be to take not just the dictation of it, but to do what many people are saying in the chat, which is try to infer some decision-making or outcomes from that. So some of the development we're looking at is based on if a clinician uses the words order a TSH instead of just having that in the documentation, could that also cause the outcome of actually placing that order? And what is the intelligence behind that? And what are the risks? So some of the risks we look at are, what if a clinician is engaging in conversations? So like, for example, I still practice at urgent care, and the other day I engaged in a conversation of like, well, maybe we should try starting a atenolol. Oh, wait, you started that before. Well, maybe we should do this instead. If that's all being documented down, how does the intelligence in the background determine what your final decision was? So those are the things that we're looking at and contemplating through. And we have a group of usability experts, user design folks, clinicians, the software developers, and so forth that just sit down and go through workflows and say, all right, if I said this, how would I want that to end up in the record? And would it be all the words, or would it be a combination of action that the EHR took along with documentation?
Great. So Jeff, let me ask you to comment on a statement from Paul Tang in the chat, picking up on the same theme. Paul suggests that Nuance, while Nuance should create the patient's story, not just a transcribed conversation, that doc should concentrate on creating the thoughtful assessment and plan. First of all, do you agree? And second of all, if either way, how would that play out?
Yeah, I actually, well, I don't know exactly how it's going to play out. The future will tell us that. We're doing a lot of the same stuff that Jackie's working on at Epic. I think the nirvana state for all of this would be that I walk into the room, I never touch the computer, the patient never touches the computer. We just have a conversation and everything auto-magically happens in the background, and a note is pushed out that is not a transcription. Nobody wants a transcription. The lawyers want a transcription. Nobody else wants a transcription. What we want is a narrative that would be written in the manner in which we would write it. This is a 60-year-old female who presents today complaining of X, Y, and Z, and something that's a good reference for my future self or who else comes along. That's not a transcription. So yes, Nuance could certainly be capturing some of that in the background. And if they could start doing that, kind of parsing the conversation into an actual medical narrative, that's great. If they're picking out the medical concepts and saying, hey, we heard atenolol, do you want to add that to the, to the medication list? They mentioned that they've got headaches. Do you want to add that to the problem list? Teeing up things that I can do, that's great. But I think what we've all learned is the medical decision-making really happens in the assessment plan. When we look at where we're going with the new billing documentation guidelines, it all is all medical decision-making now, or time's harder to do. Medical decision-making all happens in the assessment and plan. That's where we bring our thoughts together. And to the points that were made earlier, and I think Ross Capel said it, is that's where we're thinking out loud frequently, where we're tossing around ideas. You know, it could be this, it might be this, I don't know, I'm going to do this kind of thing. That's where we bring it together. How much somebody documents in there is really up to them. But I would agree that the assessment plan certainly belongs to the physician or to the clinician.
So, Peter, yeah, let me ask you a specific question in follow-up, because in the chat from some very experienced informatics folks, and I think this will probably let you get at where you might have been responding to, but Bill Tierney, as well as Mark and Ross from the earlier panel, are asking about body language. And the importance of that in this area. So Peter, actually hold for just 1 second, because I'm going to come back to you. And I think some of your answer might relate to actually video interpretation potentially, or I might ask you to see if it does. But first, let me just get Susan's input on the importance of body language and capturing the nonverbal communication cues that we're really seeing discussed in the chat.
Well, and I don't think we document them now, right? So we did it on paper, we didn't do it. And the question is how, why, and what is the return here? Because some of the body language also may be very private and sensitive, and we haven't figured out the sensitive data sharing. And as a pediatrician, you know, I'm saying, a kid saying something to me off the cuff, there has to be a way that I'm paying attention enough that I can filter out which of those body languages should be documented and which shouldn't. And I actually made a comment in the chat about, somebody said, well, the exam element all has to be, you know, spelled out. We do a terrible job of documenting what our exam is. Like, how many times do you go at home in the shower and say, yeah, I forgot to write that, right? Like, there's nuances that we're doing all the time in a personal interaction. And I think we have to decide which of those matter, and then how most easily to get them in a record that is safely and appropriately shared and documented.
So Peter, so let's say, for just as an example of a body language cue, perhaps the patient says something, and we can tell watching a video of the physician that their body language, that was a really significant thing the patient said. Their reaction is like, holy cow, you've had a mass there for, 2 years and didn't tell anybody. And they're, what are the opportunities to encode that, or to help that, for example, help your AI focus in on that detail more?
Yeah, this is a great conversation. So let me try to do a better job explaining. I apologize, it's a vacuum. Hopefully you guys can't hear the vacuum in the back. Let me just try to do a little bit job explaining what we actually do, because I don't think I did a very good job based on some of the questions that were answered. So a couple of things. Number one is, we don't put the transcript of the conversation in the note. What we do is there are parts that are word for word, but the real magic of this thing is we take the conversation and we create a clinical note, the entire note. This is not a word for word thing at all. That's really not that's a hard problem, but that's not the hard problem. The hard problem is transforming a colloquial back and forth with a lot of extraneous language into a clinically structured note. That's what the product does. That's the real invention here. So number one. Number two is, it's not just narrative. We are building it. There's a whole data framework behind that to pull structured data out of it, because the holy grail, as you all know on the phone, is to get both the rich patient story in their words about what's going on, and then also get structured data to drive all the clinical decision-making and analytics. But we all know the reality. Most docs are not going to work in a structured model. They don't have time. They don't have the patient. They're not going to do it. So this has been the challenge forever in healthcare. How do you make it work for the docs and end up with a set of rich data that you can mine and drive actions around? That's exactly the problem we're trying to solve. In terms of the video piece, in our ambient, we have machine vision in there today. So we have we have a physical device for the room, and through telehealth, you can do the same thing. And we're working with Microsoft on all of this. Just like I think Mark mentioned earlier, we do the same thing like the Connect. We have the stick figure option in there, and we use that to help the models learn what is important to be in the note. So if someone, for a simple example, forget body language, which is harder. Let's say someone touches the right shoulder on an exam and says, does it hurt here? The patient says, yes. How do you know where here is? Unless the physician says it. Well, one way is to look. There are people that are looking body language, tone of voice, what's the behavior of the physician, bedside man. There's a whole set of, I think, innovations that are going to come out of the audio and visual stuff in the world that we speak of today. But in the core solution, you'd be amazed at, again, it's not perfect. You'd be amazed at what the technology can do today. And the way it does this, you all know this, we have hundreds of thousands of live encounters between patients and physicians that we capture under our BAA and HIPAA, and we use that to teach the machine. So it has millions of examples of these examples when you have these sort of extraneous conversation. What is relevant data for a chief complaint of X for this physician? It's not perfect, but it's amazing what it can actually do. So we're really trying to push the envelope on that. And there's going to be a lot of areas where it's going to have to evolve in the core accuracy, what's in a structured data, what can you use the audio and video to do? For example, we have a bunch of startups that want to use the audio to do this depression screening stuff. I'm sure many of you have heard about that.
Peter, I'm gonna hold it there for 1 second because I have a question for Susan, and then Marshall put his hand up.
All right,
we'll get to Marshall.
perfect.
Susan, you are our family-centric representative on this call, and let's think about the range of ways families express themselves, and let's look at realizations in the AI community that there are disparities in how well AI algorithms work for different groups. There's no question that families will come across a whole range of different levels of expressiveness, different levels of verbosity, different vocabularies and languages that they use. And these may be predetermined somewhat by geography, by culture, by sometimes even could be race and ethnicity related factors. So how do we make sure that we don't increase disparities in the way that some very prominent AI efforts from some of the largest tech companies in the world have inadvertently done?
That's a great question, and I don't have an answer except to say we can't repeat what we did with the textbooks with all the dermatology pictures of Caucasian pictures of rashes that nobody knows what the heck they look like in the majority of our population. So the right answer, I believe, is to start focus 80, let's overcompensate. Let's focus most of our A work on the people who are least able to access and we have the least amount of information on, and then work on what we're used to uncomfortable. Let's start with the uncomfortable piece that we don't do well and tackle that first. That's what I think we should do. And we also have to remember that families are complex, right? We were talking about ambient, somebody wrote in the chat and it's true. Like if you've ever been in a pediatrician's office, there's 62 kids screaming, except during COVID because you're only allowed one in at the time. But, and there are also more, we have to be careful. We've been talking about in the room. We are moving to virtual care more and more. We're moving to the ability to interact in synchronous and asynchronous ways. I don't want to get rid of the exam room because there's really powerful things that happen there, but there's a lot of care that's delivered that's important, and a lot of it's not by physicians. So how the heck do we incorporate lactation consultants and social workers and the mental health piece of all of this, which probably is, and the zip code, which may be more relevant than anything we ever write a prescription for. And I think we have to start with the people who are most disadvantaged first.
Thank you. This is such an important topic. I want to give other panelists a chance to respond to this question, which is AI generated disparities based not only on the algorithms, but on what I'll refer to coldly as the training sets and warmly as the human families that these algorithms are trained on.
I'll respond. I think That's exactly what we need to be focusing on. I'm thinking a lot about that right now with the vaccinations and who's getting vaccines and where. And as we develop help to those that are using EHRs in figuring out how to send out scheduling tickets and how to make sure that the different populations are being vaccinated in an order that is equitable and really, really helpful to the community. That's one of the places that we're looking at it. With that being said, I just want to pivot back to how an exam room or outside of an exam room can look at patients with disparities. I think I was actually speaking with Ya from Vanderbilt just the other day about how voice is kind of the universal grounding space, in that everyone grows up with voice. And so if you are in a room with a pediatrician and you have 2 kids around, and if I turn to my computer and say, hey, Epic, remind me to send that family a notification in 1 week about their son's birthday or something random, it's not just me that's saying it, it's the mom or dad or guardian in the room that kind of perks up. And even the kids that are sitting there looking at their, tablet and engaged in some kind of game, they all of a sudden are like, whoa, she's doing something with technology that's actually engaging us with voice. So I think there is something to be said about how is it that we use our technology both inside the room and outside the room to really connect on a human level? Like, how is it that we show that we're caring? How is it that we show we're compassionate? How is it that we are able to maintain more eye contact with the person because maybe we're not looking at the screen as much? Things like that, I think, are also big on connecting with all levels of care.
This is great. And I'm going to bring up something that occurred in the chat. Peter, in 20 seconds or less, what about patients who are deaf and using sign language?
Oh, it's the tough challenges. Yeah, so obviously the conversation, the system is not geared right now to do sign language for the patient side of it. That's something we'd have to look at. I on the other side of that, though, real quick, we have had issues where people can speak, but they're deaf and using the system to speak back, or excuse me, to show back what the doctor's saying. So there's been some requests for that.
So there's actually a solution there. And Marshall, you had your hand up before. I want to give you a moment to make your comment. We have 3 minutes left in this session.
Oh, I think it's a question, and I think I can ask it in less than 1 minute. And it's really both for Jeff and Jackie and Peter. One or more may want to respond. There have been some publications in the clinical literature from well-regarded researchers speaking to the value of contextual autocomplete as a way to help physicians either with their voice or with typing complete documentations quickly. And I said physicians, but actually some of the really good publications have been on nursing notes as well. So I wanted to, where you can reduce the time it takes to document by create a structured note that has the data you want for predictive modeling. So I'm curious about this. And in Nuance.
Hey, Ken, I don't know who you want. I mean, Jackie and Jeff and I can all answer that, I think, pretty consistently.
Let's let Jeff in since it's been a little while since he.
I'd just like to say that, yeah, it's a great idea, but I think we've all had a few really interesting texts come our way sometimes from autocorrect that we know that there is probably significant amount of work that still needs to be done in tuning that and making sure that the user also looks at it before they hit the correct. My sister, I can't read half her text because everything gets auto-corrected into something. So I think it's interesting. I think that it would require some level of conscious interaction from the provider as opposed to an autocorrect where I'm going to have to tap it and say this is what it is at this point, because I don't think the technology is there yet to finish my sentences for me.
Speaking of finishing, we are at the finishing mark. I thank all the panelists for a terrific conversation, and I'm going to turn it over to Sarah Rossetti for the wrap up and look forward to future sessions.